So, 30 minutes or less, an overview. Now you notice that the title of this talk has been carefully calibrated. And so what we're going to talk about for the next 30 minutes or so is acquired hypogonadism in men. The reason that all those words are present is that hypogonadism in children or at puberty is a totally different, more complicated topic. I'm not even going to try to address that. And of course, in women, hypogonadism becomes universal. It's called menopause, which always seemed ironic to me, the men part of menopause. But all women, if they live long enough, ultimately become hypogonadal. It raises issues, but entirely different issues than hypogonadism in men, for whom a low testosterone level is never really normal. So, what is hypogonadism? The definition of hypogonadism is a lack of testicular function. It results in a clinical syndrome that results in from the failure of the testes to produce physiologic levels of testosterone and an appropriate amount of sperm. It can be due to problems with either the hypothalamus, the pituitary, or the testicles themselves at any level of the hypothalamic pituitary testicular axis. In terms of jargon, primary hypogonadism means that the testicles have failed. Secondary hypogonadism means that the pituitary is not sending the correct signals to the testicles. Theoretically, there's also tertiary hypogonadism, which would be hypothalamic disease. I'm not going to touch that. In men, hypogonadism is relatively common. It increases as people get older, as does almost everything else, I suppose. In middle-aged and older men, the incidence is probably in the order of 6%. Age is a risk factor. Obesity is an important risk factor, as are a variety of comorbidities. People who are sick, in general, from almost anything, tend to have lower testosterone levels. People tend to be symptomatic if they have testosterone levels less than roughly 300. So primary hypogonadism is relatively straightforward. It's not enough, and I actually often see this in clinical practice, it's not enough to measure a testosterone level, say that a person's testosterone level is low, and we're done, we just need to give them testosterone. To me, that makes no more sense than saying a person is anemic and giving them blood. A low testosterone level is a problem that requires definition. We need to know what is causing that, because it often will have broader health implications. So if somebody is shown to have a low testosterone, and typically that's the first test that we'll get, we'll talk about why you'd measure that in a moment, that should be followed up with a measurement of gonadotropins. And then similar to the thyroid that we've just talked about, there's a typical negative feedback mechanism. So if testosterone level is low and LH and FSH are high, that means that the testicles have failed, the pituitary is working normally and trying to stimulate the malfunctioning testicles to work. That defines testicular failure or primary hypogonadism. There are lots of causes. There are congenital ones, including Klinefelter syndrome, which is XXY, congenital adrenal hyperplasia, which is an enzymatic defect where the adrenal glands produce an excess of androgen. Of course, if you do surgery and damage the testicles, trauma can do it. A variety of drugs will interfere with testicular function. Orchitis, of which viral infection with mumps is the most common. Chronic liver and kidney disease can interfere with testicular function. Hemochromatosis will be on both lists, actually. Iron deposition can damage both testicular function and pituitary function. And then there are a variety of infiltrative diseases and other diseases like sickle cell, vasculitis, and amyloidosis.
On the congenital disorders, is there any possibility that we will just not see those until adulthood, or are the congenital disorders more like we treat them in childhood as well? Do we know about them?
The question was, if someone has congenital hypogonadism, is it necessarily expressed at puberty, or may it not present until later in life? And of course, the answer is yes. It can be either one. Secondary hypogonadism means that the pituitary is failing to send adequate signals to the testicles for a variety of reasons to make testosterone. And, of course, that's characterized by a low testosterone and an inappropriate lack of gonadotropins, LH and FSH. And so, of course, this can result from hypopituitarism from any cause. If someone is secreting excess prolactin, that actually suppresses gonadotropin secretion. As far as we know, prolactin only has one function, which is to permit a woman who's delivered a child to produce breast milk. But men make prolactin too. Men also have nipples. To me, that's evidence that Mother Nature has a sense of humor. Systemic disorders can interfere with pituitary dysfunction. Any significant hepatic, renal, pulmonary, or cardiac disease, severe weight loss or malnutrition causes a temporary, sometimes called eugonadal 6 syndrome or decrease in gonadotropin productions. Conversely, severe obesity is also associated with a decrease in gonadotropins. Hemochromatosis can damage the pituitary. Any critical illness will decrease gonadotropins, really analogous to the euthyroid 6 syndrome we talked about earlier. This is called the eugonadal 6 syndrome. Why anyone would measure a testosterone in someone who's critically ill, I don't really know, but occasionally I get called because someone decided to do just that. A variety of drugs will decrease gonadotropin secretion. Opiates are probably the most notorious, high-dose glucocorticoids, and of course if someone's taking exogenous androgen, again, typically an abuse situation where they're not telling you, that of course will suppress gonadotropins. And then finally, the ever-popular and not uncommon idiopathic. So there are a variety of symptoms of hypogonadism. There are some that are more specific, and one of the relatively specific symptoms, especially in a younger person, are a lack of libido. And these are guys who are usually brought into the office by their hand by their wives or their significant others, and has said, something's changed. We used to have an active sex life, and he's no longer interested. And the guy really doesn't think there's a problem. He's just, not so interested anymore. Especially for a younger man, that's not normal, and that deserves investigation. Loss of spontaneous erections. Most people won't report that, but it's a reasonable thing to ask about. Gynecomastia is an important symptom. That should lead an investigation for hypogonadism. Loss of body hair, that's a little bit less specific, but decreased shaving frequency. Again, not something that people will typically come in and complain about, but you can ask them. Say, are you shaving? How often do you shave? Really every couple, 3 days is enough. I used to shave every day. That can be an indicator of loss of testosterone. If testicular size is decreasing, that's a hint. Of course, infertility or a low sperm count. And then finally, androgen is necessary to maintain bone density. It's exactly analogous to estrogen in women. So just like postmenopausal women are at increased risk for osteoporosis, men with hypogonadism also are at risk for osteoporosis. So if a man presents with osteoporosis or a pathologic fracture, they should be investigated for hypogonadism. Oh, last one, is hot flushes. Hot flashes, again, exactly analogous to menopause. There are a variety of less specific symptoms and signs that tend to be associated with hypogonadism, and I think usually aren't terribly useful in the evaluation, although these are things that you can talk about with patients and that often when people are treated for hypogonadism will improve. So, tired, I've lost motivation, confidence, I'm sad, I don't concentrate as well, I'm sleepy, mild anemia, loss of muscle strength, kind of some increase in body fat, which everybody has, decreased performance. So when do we test? First of all, there is no indication for routine screening. It's never necessary to measure a testosterone level in somebody who's well and who has no signs or symptoms of hypogonadism. Nevertheless, it's important to have a high index of clinical suspicion. You need to suspect the disease, and especially be ready to measure it in people who have a have concomitant disease with a high prevalence of hypogonadism. So I think it should be obvious that somebody has pituitary disease or disease within the sella. Those are folks who frequently are hypogonadal, someone who's had long-term therapy with a medication that's known to affect testosterone production, people with HIV, and especially people with HIV who've lost a significant amount of weight, people with end-stage renal disease, people who are infertile, and, as I mentioned, men with osteoporosis. So how do we, we have a suspicion, we've got signs or symptoms that make us suspect a person has hypogonadism. How do we evaluate? Well, first, we do our history and physical and look for signs and symptoms. Next, we check testosterone level. It's best to measure testosterone level in the relatively early morning. Testosterone has a diurnal rhythm. Levels tend to be highest first thing in the morning. Someone has a normal testosterone level, you're done. Someone has a low testosterone level. Next, we need to exclude reversible illnesses. We need to find out if they're taking any drugs that affect testosterone production, if they have weight loss or nutritional deficiency. Assuming, if any of those pertain, you deal with those problems. If none of those problems pertain, you repeat the testosterone level and now check gonadotropins, LH and FSH. If on repeat everything is normal, follow up, you're done. That's not uncommon. If you confirm a low testosterone level, there's a couple possibilities. One is that you diagnose secondary hypogonadism with a low testosterone and either a low or an inappropriately normal levels of LH and FSH. Those people need to be worked up, and they should have a measurement of prolactin. They should have iron studies to rule out hemochromatosis. They should be assessed for possible other pituitary diseases, and if there's clinical suspicion, they need an MRI of the pituitary. People with low LH and FSH and very low testosterone levels, like less than 150, should always have an MRI. If testosterone is low and gonadotropins are high, then you've diagnosed primary hypogonadism. If somebody is relatively young and has typical physical findings, it's reasonable to check a karyotype. Those people probably also should be screened for hemochromatosis, but those people can then just be treated. Treatment is generally testosterone therapy. Pretty straightforward. There are some people who should not get testosterone therapy, even if they're hypogonadal. So contraindications clearly are people with prostate carcinoma or breast carcinoma, uncommon with men but exists. People have BPH. Testosterone can stimulate prostatic growth. If someone is not having urinary symptoms, even if their prostate is a little bit enlarged, it's generally safe to treat, warning people to look out for urinary symptoms. But if someone's already having trouble peeing, then testosterone is not a good idea. Testosterone stimulates red blood cell formation, so generally people who are polycythemic should not receive testosterone. And then there are a couple things that you should be seen by your local urologist before you start therapy just to make sure. First of all, if someone has a prostate nodule, the nodule should be biopsied before starting testosterone. It's good to check a baseline PSA level before starting testosterone therapy. If you have a PSA of greater than 4, that's someone who needs a prostate ultrasound and probably a biopsy. If you're somebody who has no risk factors for prostate carcinoma. And if you're somebody who's at increased risk for prostate carcinoma, which really includes African American men and men with first-degree relatives with prostate carcinoma, then the cutoff is a PSA of 3. So what are we trying to accomplish with testosterone? Well, first of all, we want to make people feel better. So we can improve sexual function and activity. We can improve their muscle mass and strength. We can protect their bone mineral density and potentially decrease risk of fractures, although actually there's no long-term study that proves that works. And just help people to feel better, improved energy level, improve their mood, their motivation. And in people who have mild anemia, we can normalize their hematocrit. Typically, we're targeting levels in the range of about 350 to 750, which is the the young male normal range. What are the adverse effects? Well, there are certainly some well-recognized side effects that we need to watch out for. Erythrocytosis is probably the most important. Testosterone also is responsible for the development of acne and oily skin, and it happens to everybody at puberty. But if you give a hypogonadal man testosterone, they may develop the same problem, which most people don't like. It can cause a previously undiagnosed subclinical prostate carcinoma to become clinically evident, or it can stimulate the growth of metastatic prostate cancer, and of course will decrease fertility because it will decrease gonadotropin production. Then there are uncommon adverse effects that are kind of maybe or maybe not. Gynecomastia. Testosterone is converted to estrogen. If someone is getting too much testosterone, maybe that may cause gynecomastia. Not a common problem. Certainly can stimulate male pattern hair loss, which I'm a great example. If you are genetically predisposed, testosterone drives male pattern hair loss. If someone has breast cancer, it may exacerbate that, and it may worsen obstructive sleep apnea. So if we decide that somebody is a candidate for testosterone therapy because we've diagnosed either primary or secondary hypogonadism, and they do not have any contraindications, then most of the time the treatment is to give testosterone. Testosterone is always given through the skin. Oral testosterone actually exists. I don't know why, probably because it was on the market ages ago and the FDA hasn't withdrawn it. However, it is hepatotoxic, and so we never treat testosterone with oral testosterone pills. So one way or the other, we always give testosterone through the skin. Now, there's several ways to do that. One is the old-fashioned way, which is to give testosterone as an intramuscular injection in a depot preparation in sesame oil. It can be given transdermally in either patches or gels. There actually is a tiny little patch that's about the size of a pencil eraser that you can put in the upper gum. I guess technically speaking that's not through the skin, but through mucous membrane. And then there are pellets that can be surgically implanted subcutaneously, and those pellets will last for about 3 months. IM injection is straightforward. It comes as an anthate or cypionate these days. Typical dose is 150 to 200 milligrams every 2 weeks or 75 to 100 milligrams weekly. The reason that you would give a lower dose more frequently is that it's more physiologic. When you normally testosterone has a relatively stable level, there's a diurnal rhythm and it goes up and down somewhat during the day, but it kind of fluctuates like this. If you give a testosterone injection, there's a large burst and then a relatively large decline. So if you're using smaller doses more frequently, you get less of that phenomenon, less of a surge and a drop. Yes, patients are typically taught to give that to themselves. The advantages of IM testosterone is that it's been around forever. There's long clinical experience. It's inexpensive, especially if people are taking it themselves. Some people will come into the office for injections, and that increases the cost substantially. There is dosing flexibility, which is a good thing. Disadvantages are that depot testosterone and sesame oil is a relatively viscous material. It requires a relatively large needle to inject. It hurts. So it's not really necessarily fun to give. It's less physiologic. And probably because of those spikes early on in the course of testosterone, there are supraphysiologic levels of testosterone that therefore cause a greater tendency for erythrocytosis. So what can we do instead? Well, there are testosterone patches. Patches are nice. They're applied to the skin. They're changed every day. They give testosterone levels that are more physiologic. They're applied to non-pressure areas. A non-pressure area means that an area that you're not going to put pressure on when you're sitting or lying down. So not on the buttocks, not on the hip, not on the shoulder, because when you sleep or sit, you may put pressure in those areas which can affect absorption from the patch. So typically upper body, abdomen, lower back. Advantages are that testosterone levels are consistent and relatively physiologic. There's less risk of erythrocytosis. If someone is having adverse effects, you take the patch off, and in a matter of hours, the testosterone is gone, so you can rapidly withdraw it. Disadvantages are that the adhesive may irritate the skin. If someone exercises or sweats a lot, it may not stick well, requires a daily application, and it is more expensive. Gels. There are now 4 of them on the market. They are widely advertised. So this is a big area for direct-to-consumer advertising. Patients will come in with a brand name in mind. The dose varies because different preparations have different concentrations. Typically, we're giving 40 to 60 milligrams that's administered via a metered dose pump and is applied directly to the skin. Depending on which one, it's either applied to the shoulder. There's another one that you give under the arm, almost like underarm deodorant. There's another one that's rubbed into the thigh. They're all therapeutically equivalent. Just use the right application process for each specific preparation. Advantages are that they work, they're physiologic. You can get levels that are almost anywhere you want in the normal range just by adjusting the dose. There are no injections, which is nice. They tend to be gentle to the skin. And again, you can rapidly withdraw it if there's any question about adverse effects. The disadvantages are that, first of all, a testosterone gel can be transferred if someone else touches the gel before it is dry. That someone else, or if they get their hands on it. So that someone else may be a significant other. And if someone has skin-to-skin contact with their significant other with any degree of frequency, she may pick up some testosterone and grow a mustache, and then nobody's happy. So important to avoid that. And it simply means that you give it an hour to dry. If someone applies the testosterone and the mood for romance strikes, you put on a T-shirt. The other concern is that if a child gets contact with it, that can have very adverse effects for a child, so it needs to be kept well out of reach of children. So transference is something of a concern. It's applied daily, which some people find a nuisance, and the gels are more expensive. They have to pay for all that advertising. There's the transbuccal testosterone patch, of which there's only one. It's called Striant. That's that little patch that's about the size of a pencil eraser. It's a 30 milligram patch. It has to be applied twice a day. It's applied to the upper gum above the incisor. One on one side, then 12 hours later on the other side. It's kind of a nuisance, but it has similar effects as the skin patch. It avoids skin irritation. It avoids the need for injections. And so some people like that. Once again, if you stop the patch, testosterone levels rapidly return to baseline. Disadvantages are that since it's twice daily, it's certainly less convenient. It can irritate your gums. It can cause taste alteration. It really has to be carefully taught how to put it on. If people don't apply it exactly right, it doesn't stick, and they end up spitting it or swallowing it, and it's expensive, and that's kind of an unfortunate circumstance. Sometimes they're difficult to remove and can be a little bit painful. There is no dosing flexibility. There's only one dose with this, and they are relatively expensive. And then finally, testosterone pellets. Testosterone pellets are little pellets that are surgically implanted with a small incision under the skin. Each one contains 75 milligrams of testosterone. They have to be inserted and removed every 3 to 6 months. So the advantage is you only need to do something every 3 to 6 months, and that many people find that convenient, or maybe some people. It certainly doesn't irritate the skin. It's not associated with those types of problems, but it does require someone who is able to make an incision and put in a stitch. It's much more difficult to titrate the dose because you certainly can't change that on a day-to-day basis. Occasionally there can be problems with pellet extrusion or bleeding or local infection. If someone requires a lot of pellets, that again can leave you with a lump under the skin. They're not necessarily easy to remove. And of course, if someone is having adverse effects due to the excess testosterone, it's not easy to discontinue the therapy. All right, a couple words about secondary hypogonadism. Secondary hypogonadism can be treated with testosterone exactly like primary hypogonadism. So everything that I just said in respect to primary hypogonadism applies to secondary hypogonadism. There is one other reasonable option for the bedside clinician for people with secondary hypogonadism, and that's to use clomiphene citrate, otherwise known as Clomid. Clomid actually blocks the pituitary estrogen receptor. In men, estrogen still provides important negative feedback on pituitary function. So when you give Clomid, it increases gonadotropin secretion. And by increasing gonadotropin secretion, it will increase testicular function most of the time. It's not 100% effective, but especially people with milder to moderate secondary hypogonadism, it's effective probably 80 to 90% of the time. Advantages of using Clomid are that it's just a pill, and many people find it easier to take a pill. It's very well tolerated, essentially no important side effects. In men for whom this is an issue, it will preserve fertility, whereas giving exogenous testosterone will always decrease fertility. The disadvantages are that it's a strictly off-label use. Clomid has only been approved by the FDA for short-term treatment in women for purposes of inducing fertility. There actually are no large prospective studies that have examined the use of Clomid, and there is a less than 100% response rate. Monitoring. Once somebody started on therapy, we should recheck levels 4 to 6 weeks after initiating treatment. The goal is to get somebody into the normal range, which is 350 to 800. With IM injections, typically because the level fluctuates, it's best to measure a trough level. That means the level right before someone's due to take an injection. And those levels should be adjusted to low normal. Patches and gels you can measure 2 to 8 hours after the gel or the patch has been applied. Once your levels are at target, you only need to monitor once or twice a year. Every year, a PSA should be measured and a hematocrit should be measured. 1 minute before 9. Wow, how's that for timing? Any questions? You're exhausted. You guys are very patient. Thank you. Yes, ma'am.
I have a question. Because the clinics are popping up that are doing a lot of the pellet injections, and patients start there, and those become very expensive for them. And then they transfer back to the family practice clinic. Some of those levels that are being checked are over 1,000 and so forth. How alarming should the practitioner be when you're getting levels like that? And then my other question would be the LH and FSH. Would we be looking for a ratio or just simply elevation?
Okay, ratios aren't really useful. There's just so much variability that just an elevation or a lack of elevation is sufficient. And actually an elevation of either gonadotropin is enough to establish a diagnosis of primary hypogonadism. In respect to pellets, if someone's got a supraphysiologic level of testosterone, that doesn't pose some long-term risk, especially in respect to erythrocytosis and prostatic hypertrophy. There's no emergency, but clearly they should, next time, if they're going to do it again, they should have fewer pellets. But it's not something you can immediately reverse. All right, thank you guys. Appreciate your patience and your attendance.